So, good morning, good afternoon, good evening, or good night, wherever you might be in the world, and logging in to this webinar of the Oxford Longevity Project. I am Denis Noble, a professor of medical science at the University of Oxford and one of the founders of the project. And my role is to chair this webinar, which is devoted this time to highlighting the work of three authors who have written books about the health system and why we need wake-up calls to what we need to do if we're going to meet the challenges of the next decades. One of the books, Britain, written by Martin Yuille and Bill Ollier, highlighting the veritable epidemic of diseases that are difficult to treat that is now threatening healthcare in many of the developed parts of the world. The other author we're going to be highlighting will be Samuel Shem, author of the long-standing, very popular book on healthcare, The House of God, written as a novel, but based directly on the experiences of the author, Samuel Shem, as a medical person himself, a qualified medical doctor, psychiatrist, and of course, very famous as a novelist. So we're going to begin with the first of these books, the Saving Sick Britain, and we have both the authors online. And I think, Martin, you're going to begin talking to us. Or is it Bill who's going to begin?
Yeah.
Okay, well, I always get things the wrong way around. That's all right. A chair is used to these kinds of problems. Bill, the floor is yours.
Right. Hello, everybody. I'm Bill Ollier. I'm based in Manchester, in the UK. And as Denis has said, I'm just going to give a sort of a brief resume, really, of really why we were led to write this book, and really some of the basic tenets that we really wanted to explore when we started to think about the way that we look at health and health span in terms of people's longevity. So obviously this series of talks is largely around lifespan, but we're going to focus a little bit more in terms of health span and really how we retain our health. So the starting point really for this book was we started it actually just before COVID, and we'd actually finished it by the time that COVID actually broke out, but we just managed to sort of squeeze in an extra chapter before it was off to the publishers. But we'd written it just before COVID, and really already then, before then, it was already apparent that what we call long-term conditions, and maybe I should just qualify what we mean by that. I'm talking about conditions that once you get them, that they're almost impossible or very difficult to get rid of. So I'm talking about things like chronic obstructive pulmonary disease, type 2 diabetes, cardiovascular disease, chronic renal failure, those types of conditions. And it was already apparent then that these types of conditions were accounting for a really large proportion of what we'd call poor health within the UK. And consequently, it was causing really a disproportionate drain on the NHS budget and also the health burden of how we live as a society. I think at the same time as well, when we were thinking about this book, it was already clear that the UK was having major staffing pressures in terms of how we deliver healthcare and social care as well. So this was not just in terms of GPs, but hospital doctors for a whole range of specialities, nurses, allied health professionals, and during my time when I was based at Salford Royal, you know, we were having to do all manner of things to try and look for where we could find medics to come in. I mean, people were going abroad to try and recruit people. So it's been a problem for a while. And I think the other point that struck us that you know, ever since the health service was founded, you know, since 1946, successive governments, they've constantly sort of tinkered around with it. They've altered the organizational and the funding models for the NHS and for public health. So clearly, if they've had to do that, it's never really been right, or they wouldn't have needed to try and change it. And we're not really sure that they've got it right now. So that was really part of our thinking. And from our background, I mean, we are both geneticists. I'm an immunogeneticist, and I've been interested in many long-term conditions through my career. But the majority of common long-term conditions, that they're caused by the impact really of multiple risk exposures. And although some are, you know, clearly will have a genetic basis, a large proportion of this is non-genetic, and it's potentially avoidable, or it could be reduced. And what's very clear is that many of these risks are not being reduced. In fact, they're increasing. And I think, you know, clearly we've all gone through a terrible time with the COVID-19 pandemic, but it has dramatically highlighted what our thoughts were before, that really the UK population had such poor health that this has resulted in higher rates of death and serious consequences like hospital admission in people with long-term conditions and obesity and chronic pulmonary conditions. And also the impact of COVID was felt much more in people that come from a deprived background. So these things were made very, very clear and highlighted by the impact of COVID. And I think the other thing that is almost a paradox in a way, that governments and most of the population, they're largely fully engaged with the need for disease prevention when it comes to trying to ameliorate or reduce the impact of acute and life-threatening infections such as COVID. But really, there's much less traction and less sort of concern for thinking about steps to prevent and reduce the prevalence of long-term conditions and their consequences. But in many ways, they have just as much impact. In some cases, they're causing an amazing impact in terms of the quality of life of people and the economic consequences and the pressure that they put on the health system. So just to sort of hopefully not raise people's blood pressure too much, but there are just a few sort of salutary figures that I just throw out there. We could put lots and lots more on, but just for the sake of brevity, just a few to sort of illustrate the point. Even in 2020, so that's 2 years ago, the UK was spending about £269 billion in terms of healthcare. The net revenue expenditure of public health has decreased by 13% on a like-for-like basis since 2013-14. And in fact, the amount of money that we spend on public health is less than 1% of the total NHS budget. And only a fraction of this really is spent on prevention of long-term conditions. And just to sort of illustrate that the direction is that type 2 diabetes and obesity prevalence, they've both been increasing each year. And again, more recently, just in fact a few weeks ago, the shortage of GPs. I mean, it was predicted that there's going to be a shortage of over 4,000 full-time equivalent GPs. And it's projected to rise to 6,500 in to 2023-24 and projected for 8,800 by 2030. So clearly we have major problems, and the same applies to nurses. Projected shortage of 40,000 nurses in England by 23-24. So I think we are in a bit of a pickle. We are really struggling. And in fact, just from my personal experience, I was just talking to my wife this morning, and she'd been out at a meeting where we live, and one of the neighbours had actually had a stroke. And she rang through to the Northwest Ambulance Services, and she was third in the queue. And it took 10 minutes to speak to somebody. And then in the end, she was told that they wouldn't send an ambulance and that they had to consult local services, in other words, the GP. So we're having some major problems. And I think we have to really think about the whole direction of travel in the way that we're going. Now, as I mentioned at the start, I want to talk a little bit about healthspan and its relationship to lifespan. I mean, clearly everybody on this call will know what we mean by lifespan. You know, it's easy to get your head around. It's a continuous variable in a population, but you know, clearly it can only end in one outcome, and that's death. And we can work out how long people live. But healthspan is a more relatively recent term, and it's only really been used over the last 20 years. And in fact, it was a term coined in Manchester. It's broadly defined as being just the period of a person's life that they're generally healthy and free from serious or chronic illnesses. I'll come back a little bit later to define it a little bit more carefully. So the interval between our health span and our lifespan, it's really of increasing concern. I mean, we all want to live longer and have a longer lifespan, but really nobody really wants to face the prospect of living for a long period or a long life where you've got serious limitations brought on by chronic ill health. And that the whole thing around long and progressive multimorbidity, where you start to develop lots of other conditions, it has a massive care cost as well as personal cost to people. So really, health span is a really important thing to think about. It's not just how long you live, but it's how long you stay well. And I'm sure everybody is probably familiar with the Marmot review and Professor Marmot, and this graph here is based really on information and data from the Marmot review, and it looks a little bit complicated, but if we just try and look at it for 1 minute, it's looking at the relationship between lifespan and health span, and looking at it in a shifting axis really of going from most deprivation on the left all the way through to the least deprived people. So if we look at the left-hand side of the curve, in people who are most deprived, they will have a life expectancy of in the low 70s compared to the people who are least deprived, which will be just over 80 or so. But if we look at the bottom line, which is the end of health span, we see that in people who are most deprived, it's going to be in their relatively low 60s. Whereas the people who are least deprived, it's going to be probably in their mid to late 70s. So for the most people who are suffering the most deprivation, not only are they going to live less long, they're going to live with more years of poor health. So in the most deprived, they're going to be living with 20 years of serious ill health and poor, that's the end of their health span, compared to people who are least deprived, who on average will only have 12 years before they die with the loss of their health span. So it really brings it into sharp focus. Clearly, we think it's a bit more complicated than just saying it's down to deprivation. Deprivation is probably a composite exposure for all manner of things, but it illustrates the point that there is a massive difference within our society. And really, if we're going to try and improve the health of our population, it needs us to try and bring these two curves closer together. So really, he's right. A major issue is deprivation in society. But clearly, it's more complicated than that. And if we just look at it in terms of these two sets of charts, on the left is looking at it region by region in the UK, and we're looking at the variation of life expectancy across the different regions. And on the right, we look at the different variation in health span, healthy life expectancy across the same regions. And you can see that there's a very marked range of variation depending on which area of the UK you live in. And actually, if you drill down even further within those regions, you'll see major differences even at a borough level. I worked in Salford for 7 years, and Salford city is actually made up of 10 boroughs. And even across those 10 boroughs, there was a really marked variation in terms of all manner of disease metrics, in terms of everything from smoking related illnesses to diabetes, etc., etc. So we have massive variation across our country. Clearly, there's a very important north-south difference there. The northwest only really fares marginally better than the northeast. So the whole issue of levelling up, I mean, clearly it's for the previous government, it was a big term, whether they meant it or not, but levelling up was sold to be a very important thing. But I think when they were talking about levelling up, they were considering it more in terms of prosperity rather than in terms of improved health. But really, it's probably one of the most important things that we should be considering if we're trying to level up. So long-term conditions, I mean, they are really what we would consider the modern plagues of our time. It's not just infections. If you look at some of the increases that are happening in prevalence to some of these things and the numbers of people, really, by any definition, they are in many ways, they could be considered to be plagues, but modern day ones. And they're not down to really just infections. But broadly, they're defined by lasting for more than a year, where you require ongoing medical support or limiting activities in terms of your daily life. And I said they usually stay with us, and they become more complex along the road as we get older, and they become consequently more expensive to treat. So there's the issue, not just thinking about a single long-term condition, we also have to think about multimorbidity, where we might get more than one long-term condition. And I already mentioned a few examples: chronic obstructive pulmonary disease, asthma, cardiovascular disease, diabetes, renal disease, hypertension, cancers can even be thought of in terms of long-term conditions, and certainly mental health is a massive one in terms of depression, and those rates are going up massively. Alcohol-related diseases, dementia, the list goes on. So their origin is complex, as I said. It's not just multiple inherited, relatively small genetic factors that interact, but it's how they interact with external risk exposures, so smoking, air quality, deprivation, sedentary behavior, etc., etc. So if there is any good news to be actually given from this, when we think about it that way, it is, well, if you inherit some of these risk genes, it doesn't therefore necessarily mean that you're going to develop a long-term condition. It's not inevitable. There's much more to it than that. You actually have to be exposed to certain levels of certain things to actually precipitate yourself into having a particular condition. So just to, I won't go through every long-term condition because that would just take too long. You know, if you look at the book, we provide data on a much wider range of conditions. But just to illustrate the point, UK incidence rates of diabetes have been going up year by year in the UK. At the moment, there's almost 5 million people with diabetes diagnosed in the UK, and there's probably getting on for another million of people with diabetes where it's not been diagnosed yet. But you know, if you look at the predictions, it's going to rise up to 5.5 by 2030. And at the moment, the NHS spends £10 billion on treating and managing type 2 diabetes. It's a tenth of its budget. So you don't have to be a genius to work out if this trend continues, really, and if it continues for other long-term conditions, a vast amount of the budget, of any budget, is going to be consumed by it. And again, just to illustrate the point, in diabetes, in type 2 diabetes, anyway, there's a relationship that we can see, a very clear one, between body weight or BMI and diabetes. And if you look, these two things actually mirror each other. As you go over time, you can see just as the prevalence of obesity has been rising, it is mirrored by the increase of prevalence of diabetes. And you see the same between men and women in terms of the risk and weight change. So obesity is just one, but it is really a major risk factor for chronic disease. It's associated with many long-term conditions, including diabetes, cardiovascular disease, dementia, etc., etc. In the UK, about 1 in 6 of people with heart and circulatory diseases are associated with high BMI. We're seeing year-on-year increases in obesity, not just in adults, but we're seeing this in children. And the sort of the latest figures, 28% of adults now in the UK are obese, and over a third, in addition, are defined as overweight. And staggeringly and sadly, 30% of children now are actually labelled as obese or overweight. Obesity is complex because it's also associated with a vicious circle of sedentary behaviours. So these things all interact between each other in very complicated ways. It's also associated with poor diets, with fast foods and convenience foods, also with poverty, with deprivation. You know, because you don't have much money, very often you can buy much cheaper high calories, but they're very low in nutrition. So obesity it's much more complicated factor in exposure. It's not just really what people would like to say is it's a life choice. It's not a life choice. It's more of a behavior, and so it's a very difficult one to actually tackle. And many other things can impact on why somebody might be obese. Could be a genetic exposure, it could be deprivation, it could be education, the type of family you're born into, education. All of these things can impact on why somebody might become obese. So the evidence really is just as depressing, sadly, for many other chronic conditions. There are just an enormous people who develop a chronic condition now. For some, they're probably or partially at least related to increasing life expectancy. So, for example, if we're all living longer, you expect to find a higher number of people developing Parkinson's disease or prostate cancer or osteoporosis, etc. But importantly, a large proportion will be related to the changes in the way that we live our lives. For example, the strong risk contribution that smoking has to chronic obstructive pulmonary disease and lung cancers. So some will happen by chance, and there's not much we can perhaps do to that. However, the way we live our lives or what we do will have a large impact on it. And, you know, a large proportion of the risk of developing a chronic condition can be avoided or at least delayed in terms of onset. So really prevention is always better than cure. Now, there's a complex relationship between many of these long-term conditions. As I said, this is often seen as multimorbidity, and you actually see a downward spiral of disability over many years. So for the example that I gave before of type 2 diabetes, people with diabetes are at a much higher risk of developing things like cardiovascular disease, atherosclerosis, renal failure, retinopathy leading to blindness, peripheral nerve damage leading to foot ulceration and infection, and sometimes this leads to amputation. So you can see this becomes increasingly complex to deal with multi aspects of healthcare. It becomes very complex indeed. And very often this results in many drugs being prescribed. And, you know, once you get over 2 or 3 drugs together, our knowledge about how those drugs interact becomes a lot less clear. And you can get interactions that really are just due to the polypharmacy. And some of these patients really on with multiple conditions, you know, in some situations, they can be on more than 25 different drugs. So the human cost is for sort of living for many years with increased disability, and really, you know, it's a very miserable life that some people live. So this is just to illustrate really, as people get older, you see this increase in multimorbidity, and clearly for certain peoples with certain diseases, this is extremely, you know, an ongoing pathway. So sedentary behavior is a major risk factor. You know, physical activity is one of probably the most important things for chronic health and disability and a premature death. Higher levels of exercise can extend your lifespan, certainly by 3 years, but it'll also improve your health span as well. So the data is pretty convincing. However, I would say in the UK, probably only a minority of doctors are familiar with the Department of Health recommendations for exercise. And in the USA, 4 out of 5 adults fail to achieve the recommended levels of activity. And in a recent survey, only 20% of adults in the UK, they took no physical activity at all. So less activity is associated with lower income and poorer education. This reduces activity, was already apparent in teenagers, and the activity gap between rich and poor continued to grow up to the age of 85 years. So many attempts have been made to increase physical activity, but most have had limited or very transient success. So the major missing factor really is social cohesion, and Martin will talk about that soon. So really, I could go on with all of these risk factors, but smoking, tobacco is another one. I mean, this is a really big one, because really smoke contains many carcinogens and irritants, and it's even more complex because it has the addictive properties of having nicotine in it, and it's a leading cause of preventable death and chronic disease. So the evidence to link smoking and cancer came in obviously people are aware, in 1950 from Doll and Hill, and later it was revealed that it was linked with cardiovascular disease and respiratory diseases. So, you know, way back then, people could have taken action and policy action to ban smoking, or at least restrict where you did it, because at that time 80% of men were smokers, including the Prime Minister himself. But clearly there are many issues, because this is a great mechanism for raising tax revenues, and clearly there's been a lot of lobbying over time from industry in terms of the tobacco industry. So ironically, in 1693, MPs banned smoking in Parliament, but it took them until 2007 to ban smoking in public places. So many deaths now are attributed to smoking, and the level of chronic conditions where smoking is contributed really is almost incalculable. I mean, you know, it really is a very sad story. Multiple deprivation, clearly highly important, because it's a composite risk really that includes many other risks inside it really. So leveling up, just to repeat again, it's not just an economic issue, it's a health issue too. So I just want to finish off really with a life story, and this is a true life story, and I don't think it's that atypical. I think it's probably quite typical really. So this is a lady called Mrs. D, and she lived a year or two longer than most women of her average means. She died recently, aged 84, but for 6 of her 9 decades, she was not only morbidly obese through her life, but she also endured deteriorating health. In her early 40s, she went on to medication for hypertension. After childbirth, she had a prolapse of the uterus requiring surgery. Just after that, her neck and shoulder muscles became stiff with a condition called polymyalgia, and for this she was treated with high-dose steroids. She then had to have a long-term foam collar that she wore for many years, with osteoarthritis in her neck and spondylitis of the neck. She had an operation for that, but the pain persisted and she went on painkillers for the rest of her life. In her 50s, she had gallstones and surgery. In her 60s, she developed angina, survived a subsequent heart attack and went on to more pills. In her 70s, she became diabetic, type 2 diabetic, and had more tablets, finally ending up on insulin. Kidney problems followed, including recurrent urinary tract infections, leading to long-term catheterization and antibiotics. She developed nerve damage to her foot from the diabetes, causing it to drop. She had a mobility scooter. She was probably, and she had carers that came in 3 times a day. The wide range of pills she was on probably caused the dramatic skin rashes that she then developed. These gave rise to ulceration. She was in and out of hospital for many years and received social care until she eventually developed pneumonia, went into renal failure, and after terminal organ shutdown, died. So, I mean, very sad story. And it is just a very salutary story where it shows you that there is an ongoing progression of ill health. And actually, if we had done something about it much earlier on, we could probably have had a very different story. So that's where I'm going to leave it, and Martin's going to pick up much more in terms of how we think things can be looked at in a different way in terms of healthspan.
Thank you very much, Bill. Just a note to say that we're running just a few minutes over our expected scheduled time, so we need to keep things moderately brief, but over to Martin.
Thank you, Denis. So first of all, I wanted to thank the Oxford Longevity Project and Denis in particular for suggesting this this webcast. I appreciate that very much. And as Bill implied, I'm going to deal more with the solutions rather than the problems. So I've entitled the talk "The Health Society: How to Save Sick Britain," which is a reworking of the title of the original book, so as to emphasize the fact that we're talking about the Health Society. Let me just summarize what I'm going to say. First of all, I'm going to suggest to you that obesity, like COVID-19, spreads from person to person. It's a pandemic that requires action at the population level. then in order that we can live our lives in a state of health, we first require a positive definition of what health is, what health means. And then we can discuss how to convert that definition into policy reform as the health society. I wanted to sidetrack very, very slightly by bringing to your attention what Heather Hallett said yesterday when she launched the UK's COVID-19 public inquiry. We've had 23 million cases of COVID-19 in the UK, and though that number is not that different from the number of people suffering from the various long-term conditions that Bill has referred to already. And what she said in opening the inquiry was, there is one word that sums up the pandemic for so many, and that is the word loss. Although there were positive aspects of the pandemic, for example, the way in which communities banded together to help each other and the vulnerable, millions of people suffered loss, including the loss of friends and family members, the loss of good health, both mental and physical, economic loss, the loss of educational opportunities, and the loss of social interaction. Now, all those areas of loss are exactly what arise also with the development of the long-term conditions, which Bill's described. In a sense, part of the solution lies in what she calls the positive aspects of the pandemic, namely the way in which communities banded together to help each other. So she summed up, in a way, the situation not just for an infectious epidemic, but also for all the various long-term conditions that we've been focusing on. Obesity is a contagious pandemic. In the book, we talk about, we use the word plagues, the plagues of our times to describe pandemics. We didn't want to use the word pandemic because it's a word that was technical, but now has entered the popular arena. And so I'm happy now to refer to the different conditions that we've been talking about as each constituting a pandemic of one sort or another. And obesity is a pandemic, of course, is a global phenomenon, and obesity itself is globalized. Without going to all the statistics on obesity around the world, just remember that 17% of girls in North Korea are obese. So if you think of what the situation of North Korea is, and you recognize that nearly 1 in 5 girls are obese, you can get an idea of the scale of the problem that we're talking about. Obesity is, of course, a risk factor, as Bill suggested, for diabetes, for heart disease, for cancer, for depression, and so on. But it is also a modifiable risk factor. In other words, we can do something about it. The genetic risk factors we can't, at this point in time, do anything about. But the modifiable risk factors we can. And obesity as a modifiable risk factor for those diseases is therefore critically important. That's the first point. The second point is that obesity spreads through contact in social networks. Now, this is work that has been done through the Framingham study, which is a study, an epidemiological study of a town, the town of Framingham, just outside Boston, which has been going since 1948. So it's been going for 3 generations, over 70 years. And they've been following the people of that town with funding from the National Institutes of Health in the US all that time. And one of the discoveries they've made is that obesity spreads through contact in those networks, family, friends, and so on, through first degree friends and through second and third degree friends as well. So this is, although it's not an infectious condition, it nonetheless spreads from person to person, and therefore it shares that in common with COVID-19. And that therefore means that to end pandemics in long-term conditions requires action at the level of the population, just as we saw we had to do with COVID-19 lockdowns. We just had to do it. It's the same argument here. These sorts of conditions that spread through contact between human beings require action at the population level, not just at the individual level. I'm not saying there shouldn't be action at the individual level. I'm saying there has to be action at the population level. What do we mean by action at the population level? Well, it means public policy reform. And it means public policy reform to prevent or to reduce the risk of or to end the pandemics in the long-term conditions. But in order for such reform to work, it needs a clear, positive goal to achieve. And longer health span, as Bill has indicated, is just such a goal. For example, in South Korea, the government has set a goal of 75 years health span for its population to be attained by 2030. And the diagram, the illustration on the right is from the policy document for that, from the Korean the relevant Korean Institute, showing that their overarching goal is to achieve a society with healthy life expectancy of 75 years, and that is to be achieved by 2030. But we require, and actually the Koreans require, a positive definition of health in the first place in order to achieve that goal. Because the risk is that otherwise the goal will mutate from prevention to treatment. And if you look at what is happening in South Korea, if you read that policy document, you'll see that there is a tendency for them to be concerned more with improving treatment rather than focusing on prevention. It's a very easy error to make. Prevention is prevention, treatment is treatment. Prevention occurs before there are any symptoms of the disease, any visible symptoms. Okay. So in order to get this better definition of health, we need to start to define the word health. And I'm going to start with the common definition, and here's the one from Google. They define health as being the state of being free from illness or injury. And it's a very common way in which people define health. Note that it is a negative definition. It defines the absence of health. And it focuses, therefore, on treatment, not on prevention. Let's read it again. The state of being free from illness or injury, negative definition. And the example they give is he was restored to health. In other words, it focuses on treatment, not on prevention. It provides no hint in that definition on maintaining or prolonging health, none at all. Okay. Does the World Health Organization do any better? Well, I have my doubts. When you look at the World Health Organization Constitution from going back to 1948, it defines health as being a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. So they recognize that a negative definition is not enough, not merely the absence of. And then they introduce this term of well-being. The trouble is the word well-being is itself pretty imprecise. It easily mutates into a negative definition. For example, well-being means not being unwell, and therefore it doesn't take you any much further forward as a definition, as a positive definition. But has the WHO improved? Well, in 1986 it issued the Ottawa Charter, and this identified for the first time what it called the fundamental conditions and resources for health, and it listed these as being peace, shelter, education, food, income, a stable ecosystem, sustainable resources, social justice, and social equity. But this is not presented as a definition of health. So it doesn't actually fit what we need, which is that definition. However, when we come to Lawrence Hamilton, and I believe Lawrence is here, so I hope he doesn't mind I've stolen that photograph of him just to show people what he looks like. He has a completely different starting point. He argues that political theory, he's a political philosopher, he argues that political theory should have human needs at its heart, rather than theories of justice or rights. And he identifies these human needs under three headings of vital needs, agency needs, and social needs. And then in one sentence in his book, which I read, all of which I read with interest, but what made me sit up and really think was the one time he uses, I think it's the only time he uses the word health in the entire book. And he refers to it as being almost in an offhand way, if I can say that, that health is the state that exists when these needs are optimally satisfied. In other words, health is what we need. Now, he's mainly interested, obviously, in political philosophy, political theory, and I'm mainly interested in health. But there we are, we met at that particular point, and a light bulb went off in my head. Health is what we need. It is the composite of satisfying those needs. So health is what we need and what many want, of course. And the three headings that he has break down as follows. The vital needs he identifies are nutrition, shelter, clothing, periodic rest, exercise, and social entertainment. Well, when I read that list, I thought, yes, this is spot on. And then I saw social entertainment, and I thought, well, that's an odd one. Why is that in there? Why isn't that in there as a vital need? And I then read about the situation of epidemiology done on prisoners in the United States who are kept in solitary confinement. Therefore, they lack any form of social entertainment whatsoever. And their rates of mental decline, of mental health, of mental illness are staggeringly high as a consequence of their solitary incarceration. So that is a valid point to make on there. Each of those points can be justified and has been justified by lots of epidemiological research. So his list of vital needs is basically in line with the evidence, in line with the science. Agency needs, the same thing is actually true, though you have to, as it were, recode the terms that he uses for the kinds of terms that epidemiologists use. But for him, agency needs are autonomy, intersubjective recognition, and active and creative expression. By autonomy, he's referring to the ways in which we are, as it were, masters of our own fate. By intersubjective recognition, he's referring to the ways in which we respect each other. And active and creative expression the key word there is expression, of us being able to express in an active way, our creative aspects. And all those things are part of what is health. And there is clear evidence that an active and creative life improves people's health, okay, or extends their health span, let's put it that way. The third category is what he calls social needs, by which he means the needs that society has to maintain itself and the individuals within that society. And he specifies trains, cars, and TV. This was in 2003. I think now he would, maybe he can tell us, he would now probably add smartphones, I suspect, to the list. And these are bits of technology that really are essential for us to be able to go about the modern lives that we lead. Okay, what I would note from this list of these categories of need is that they're up for debate, and the type of debate which they involve it constitutes what real politics should be about. It means specifying these needs very precisely in ways that are relevant to our society at this time, or your society at this time. What's more, these needs largely coincide with the WHO's fundamental conditions for health. What they call conditions for health, Lawrence Hamilton is largely identifying as being components of health rather than conditions for health. It may only be one word that's different, but it makes a hell of a difference to the way in which we approach the problem of improving health span in society. So thinking of health as being need satisfaction, health as needs, is a new foundation for public policy as a whole. And we call it the health society. I'm pretty sure we coined that phrase. It's a society driven by the requirement to satisfy needs, the needs that I've mentioned. And it's a society where the value of utilitarianism, which is the predominant mode of thinking about public policy, is demoted. It encapsulates how society can reform, and it also encapsulates how society will reform. Hamilton says that it can reform, That's basically what he's saying in his book. And I'm saying that a proper reading of biology says it will. But I've relied on Hamilton for now, rather than the biological arguments, because they're easier to put over in a short talk. The health society implies change in three things. And this diagram here to the right is taken from the book, where we say there are three pillars to the health society, requiring change in the institutions, change in our communities, and changes in technology. And let me just take you through the diagram a little bit. The temple is that of the health society. It starts by ending the modern plagues or the pandemics. And the goal is the optimal satisfaction of the needs that define health as the supreme purpose of public policy. And there we are, the three kinds of change, 1, 2, 3. What does this mean in terms of institutional change? Well, there are a lot of proposals in the book, but I'm just going to pull out three of them. First of all, the idea is, and of course this is UK specific, but it could be modified for any other country. The Deputy Prime Minister, largely a role played by a person who steps in when the Prime Minister goes off on holiday. This role should be boosted so that that position takes direct overall responsibility for coordination across government of implementing the health society. It requires reforms in industrial policy, employment, transport, planning, housing, education, leisure, sport, food, and healthcare policy. All of those, and quite a few more. One of the key instruments that can and should be used is something that has existed in the UK since 2000, for the last 15 years or so. 2008, I think it was. And these are the national risk registers and the local risk registers at local government level. These are registers of risks that face communities or the nation, and include things like floods, but also include infectious diseases, and they always give the example of flu. But it should include also the risk from the pandemics that we're talking about. And it requires the relevant organizations, the government, and national and local government, to create action plans for ministries, for communities, for businesses and services to tackle those risks. That action plan, of course, then has to be implemented, and that's where you're into changing the way in which things work. So we already have the legal framework and the organizational framework for implementing a policy that would enable us to implement the health society. The difficulty is that these registers have fallen into disuse and were barely used during the COVID pandemic, for example. One ministry which is particularly important, of course, is the Finance Ministry, the Treasury, and it needs to have a priority that it will finance decisions based on the extent to which they satisfy health as needs. Something which probably will cause heart attacks, well, not too many heart attacks in the Treasury itself. Community change. By this, again, we have the foundations for it, we think, in the National Health Service's health check system, which provides a regular health check to people. But we think it needs to be profoundly reformed through the introduction of what we call in the book health society professionals and health champions. Health society professionals are essentially nurses or similar professionals who combine the role of nurse and community development worker, so as to reach out to the communities which they serve from within a general practice, or maybe from some other local health center like a hospital or whatever. And their job is to work with the various stakeholders, which I list below. They also work just to support what we call health champions. Now, to give you a rough idea what we mean by health champions, they would include the 750,000 people who volunteered in the space of a week at the beginning of the COVID-19 pandemic and who wanted to help out. I don't know if people remember, but that's how many people volunteered spontaneously. That's over 1% of the population, 1 in 100 health champions came forward to say, I want to help prevent this disease. We're saying a comparable number could easily be found on a more permanent basis, on a more proper footing, to champion the diseases of the long-term conditions. So the role of these people is to engage all stakeholders, employers, public and private services, and the third sector. Some employers already, private employers already have policies, and so do public employers, have limited policies for looking after the health of their employees. But this needs to be far better organized and far better coordinated by local and national government. And that's what we call for. When it comes to services, they too need to involve their local communities, in particular, when you think of the education system, the schools, primary schools, secondary schools, tertiary education, leisure organizations and healthcare organizations working with their communities and the people and organizations in those communities. And finally, the third sector, the voluntary sector, all ready to and willing to go to support this kind of thing. People want to help, but we are not letting them help because we don't provide the coordination and support for that. And on the back of that, we could set as our first healthspan target, well, I think I'm being a bit optimistic here, of 75 years. When Bill put up the graph of healthspan and lifespan, maybe 75 years works in Korea. I think we're going to have to be a little bit less ambitious in the UK. Maybe 70 years would be a more realistic target over a reasonable policy lifespan to achieve the healthspan target for the nation. But we need to set that target, just like Korea has done. If they can do it, we can do it. Technological change. Well, I think I can sum that up in as nationwide action research, by which I mean the combination of action to improve research and to improve health span, at the same time as research into how to do it. I think the two things come into being side by side. We need research to identify, validate, and improve what we call risk reduction biomarkers. So these are biomarkers in an easily obtainable biological fluid, but probably blood as most reliable source of such biomarkers. It's tested, they're like any other biomarkers, but they are followed over time in individuals to see to what extent they predict reductions of risk of subsequent disease in the people in the understudy. And then that requires the testing of both new and retained samples to assess declines in risk. You've got to retain the samples as well. On top of that, we need a secure, integrated, ethical, national data management system for health as needs. In other words, a big computer system to which there can be no direct commercial access, so that wouldn't be acceptable to the population. That doesn't mean that there can't be collaboration between public and private systems, in other words, academics basically, and private companies, to discuss how to achieve particular goals, achieve particular results from the data. And finally, we need to measure health as needs, i.e. measuring the vital social and agency needs in individuals and communities. And that would then generate a health society index. It's comparable to what Sally Davis has proposed, but it's focused on needs rather than on treatment. So in conclusion, what I've said is that pandemics in long-term conditions afflict us in the UK and elsewhere. Their prevention, in other words, the extension of health span, requires risk reduction. And it is through systematic prevention, which we call the health society, that we can achieve that. If you want to get in touch with me, there's my email. Thank you very much.
Well, thank you very much, Martin. Simply wonder whether Professor Lawrence Hamilton is still online, and if so, whether he would like to say anything in response to the presentation by Bill and Martin. Lawrence Hamilton, are you there?
I'm so sorry, I got the time slightly wrong, but so I only have a few minutes as I have another meeting to go to. I thought it was at 5. But just to say congratulations to Martin and Bill for a fantastic book, and thanks for the reference to my work. It's really great to see it in this kind of public policy format. I don't really have very much to add. I think you've hit the nail on the head as regards one of the ways in which you can interpret what I was trying to do. What I was actually trying to do was, as you said, very much broader than health, but health was front and center in certain sorts of ways. I'd just like to say that, I mean, maybe just say 3 quick things. The first is that, as I think I said to Martin originally, the great thing about this book is that it's not just about Britain. It's also applicable across the world. You know, I'm from South Africa, and a lot of the types of plagues that you're referring to can be expanded and contracted and applied to very many contexts, including a place like South Africa. So I'd really sort of suggest that you expand it beyond the focus on the UK, and because I think it really has great force, and many places would do well to follow it. I think then the second point is just about your notion of healthspan or the health society. I'm not going to say much about healthspan, that's out of my league, but why not just call it the healthy society? But I'm sure you've got a good answer to that, because it would be a nice way of bringing together some of the ways in which well-being is understood, especially in the work of Amartya Sen and his capabilities approach, as well as a needs-based approach, and being able to bring together, again, a more broader framework that you discuss in terms of well-being, and then focusing in on health exactly. And then finally, what I think to be your most important point, and I think this is where what you're really driving at, the point about prevention as against treatment, or not as against treatment, but as a better way of proceeding. And I think you're absolutely spot on that if we set ourselves these sorts of goals, whether we articulate them in terms of needs or rights or whatever, if we set ourselves these goals, then we have a possibility of shifting our attention away just from treatment to prevention. So, and I really like the way you brought out some of those institutional proposals as well, Martin. My interest is really on those institutional reforms in politics, I suppose. And all I'd say to end off is that, and this does speak to a health concern directly, is that one of the great difficulties we have in democracies, at least as the way they're set up, is that we don't have a very good way in which we can receive the needs-based information from the populace and feed it into objective analysis that comes from, say, medical research and other kinds of research. And the work of Amartya Sen, and I hope my own work, has tried to show that we can't get anywhere without both a subjective view as regards people's preferences and needs, and also an objective account. In fact, the only way we can get to an objective account of, in your case, health or health span, would be to have some kind of rearrangement of our political institutions, such to the extent that they enable our politicians both to have the information at hand as regards people's health, but also to be held accountable in those terms. In other words, in the terms of whether they're responding to that information.
Okay.
Yes, very briefly, if you can, because
yes,
I want
very
to
briefly.
Yes, thank you.
Expanding beyond the UK, our original idea was to include a colleague from France. Do you remember that, Bill? But then Brexit came along, and we thought, oh God, this is going to make life difficult. We better just stick to the UK. we need to talk to our primary audience first, and then we can worry about our friends in other countries in due course. But I agree with you entirely. That was our original intention, was to cover at least most of Europe. Healthy society rather than health society. Problem with the word healthy is that it implies that it lets in your institutional reforms as well as being a separate legitimate goal. That's the problem with the word. Yeah, and we feel that health itself is sufficient to drive through the changes that we need. And you appreciate the institutional reforms that we're suggesting. You're suggesting them too, but we're not labeling the thing as being, we need institutional reform, you know, we need more democracy, that kind of thing. We're labeling it as this is part of health. That then also comes out of the biological arguments around all of this, and I haven't really gone into all of that. It does require a separate, detailed discussion. Maybe when you're over in the UK next time, we can get together and I can sort of spell it out to you in simple terms why I think what the biological argument is. So I've covered really the 3 points that you've raised.
Thank you very much, Martin. Well, we'll leave it to Martin and Lawrence to sort that out when they eventually meet. Meanwhile, I just want to check what the present situation is in relation to our panel. Do we at the moment have Samuel Shem online? I don't think we do. Now, two things that we could do at this stage. One would be that we just continue the discussion of the issues raised by Martin and Bill's book. The other would be for me to give a brief introduction and comment on Samuel Shem's work. I actually, at the moment, instinctively prefer the former because we're already something like 20 minutes away from the end of this webinar, and I think we've got enough issues to discuss that we can probably leave the kinds of issues that Samuel Shem raises in his novels about the state of play in health and its delivery to another time. So my very strong instinct is that we go with the discussion we're having at the moment. And if we take that line, the suggestion I would have would be to discuss the following. What strikes me very strongly indeed in this discussion is the following. The costs of healthcare, particularly because of the epidemic, as we might call it, of diseases of the kind that we're talking about in this webinar, have simply shot up enormously. The sheer cost of many medications and treatments is itself a major factor in the economics of a healthy society. And yet, the prevention methods don't cost anything like the same kind of sums of money. Now, I don't know what everybody else in this webinar and discussion would see, but what I see when I look at what my colleagues are doing in delivering healthcare is that they're spending as much time as they can on dealing with the big problem, which is the curing of people whose diseases are almost incurable. There is very little emphasis, it seems to me, on the prevention side. Many of the techniques for prevention, exercise and observations too, they just simply don't seem to figure as strongly as they should. Is that a general feeling? I mean, I'm really putting out that for discussion to see whether I'm highlighting here an important difference. The costs of dealing with cure are often now exceedingly high. The costs of dealing with the prevention are not so high. Is that a correct analysis? And what do we do about it? I want to throw that out and see what emerges.
I could comment on that.
Please, yes.
And I think you're right, but I think there's probably been quite a lot of activity focused around early detection of disease. They've not gone all the way back to trying to prevent it, but they have put lots and lots of money, obviously, into screening. And they're screening for early diseases because they think they can treat them, and in many cases they can treat them effectively, you know, and you know, we're certainly not knocking, you know, early screening for colorectal cancers or even, you know, early screening for people who are borderline pre-diabetic. I mean, clearly there's a lot of sense in that, but that seems to be where a lot of the emphasis has been placed. Okay, perhaps with people who are pre-diabetic, they can get them to sort of come back off the cliff edge to sort of come back into more of a normal state. But by and large, that seems to be where the emphasis has been played, but not just in terms of obviously developing new treatments and how you treat people better and keep them alive, but actually it's picking up early disease. And as Martin said, really, we need to go one step before that.
That's a small help, isn't it? Because you are then hopefully, to take diabetes as an example, you're hopefully identifying the problem while it is still possible to push it back with suitable help to the individuals to take the necessary dietary and other measures. So yes, that could help. What I had in mind was more the fact that quite a number of what we might call preventative solutions or activities are not themselves intrinsically expensive to do. Receiving good advice on diet and having it explained to people carefully, and with social help, because it isn't enough, is it, to just tell people you've got to be, there has to be a way in which, and there are professionals who can try to do this, of course, we would call them the coaches to a better lifestyle, I suppose. That kind of thing is, it's manpower that's needed and professionals who can do it. But if we were able to push back with the early detection you're talking about, we might be in a better position.
Yeah, and I think it's also health education. I mean, the big problem always is that within the richness and range of our society that we live in, there are many, many groups that are what we would call hard to reach groups. You know, these may be, you know, the guys who go to football,
yes, exactly.
pub. It could be certain heritage groups and you know, so you've got to deal with it in the way that Martin said. It's no good some you know, highly educated suit and tie public health education person going into those groups and trying to tell them what they should be doing. The best people who can deal with that are the people from within the communities themselves, because they understand it and they have
exactly so
in the culture
yeah.
to do it. So the only way you can solve this is by doing it from within. You know, to do it and try and force it top down is, I think it will work in some areas, but it will definitely not work in you know, in many of the situations that we have to deal with.
No, indeed, yes, that's right.
The lack of public education and the cost of that has been exemplified really with the COVID-19 pandemic to a terrible extent. Now, I believe we spent about £500 billion in the UK during the lockdown period. That is a fantastic, I mean, 500 billion pounds is a huge amount. Of course, the chronic diseases are eating up money over a longer period, but are eating up money at that kind of rate anyway. And without the public education that allows people to realize and to know that they just need to wear a mask. Do you remember how difficult it was to persuade people that they needed to wear a mask at the beginning of the pandemic? There were articles by leading lawyers and editorials in newspapers saying, I have the freedom to not wear a mask, blah, blah, blah. It was all ludicrous, absolute rubbish. And the reason it was listened to is because people are just not educated about health at all and how diseases work and so on. And that's lacking from the school curriculum, it's lacking from university curriculum, it's just lacking from everywhere for people generally to understand those issues. And so that seems to me to be something which could be done with minimal cost to improve public education. It's just a matter of educating the educators.
Now, I was going to find out whether there are any online questions that have been coming through. I can't see anything in the chat line, so I wonder whether those who are running the have seen any online questions that we should be drawing attention to. While they're checking on that, they just send a message to me if that is the case. I'd like to highlight another issue which comes out in the book we're talking about, Saving Sick Britain, which is the question of focus on the level at which these diseases occur. We have, it seems to me, over the last 30 years or so, during the whole of the Human Genome Project in sequencing, being focused on the idea, which indeed is how the Human Genome Project was championed in the first place, sold if you like, that somehow through knowing all of that detail at the low level of the molecular processes involved and the molecular information that is in the genome, that somehow the cures for cancer, for Alzheimer, for diabetes, for cardiovascular disease and so on, would somehow come and appear, well, we were told within 10 years of full sequencing of the human genome, and it hasn't happened. Now, as you, Martin and Bill, also emphasized earlier, that's not to say that the sequencing of the human genome was a waste of time. It certainly wasn't. We needed all of that for very, very many reasons, not the least the science involved. But what I think has happened is that, first of all, not only were those promises not delivered, I don't think they ever could have been. Because after all, these diseases we're talking about now that are preventing healthy long life are precisely the ones that don't succeed in being cured by a simple gene targeted product or a protein targeted product. In fact, they're not single factor diseases at all. They are multiple factor diseases. And that's been shown by the sequencing of genomes. The very Genome Project has shown us that actually a large number of genes are involved in these extremely complex diseases. And we're clearly not going to find medications that affect, say, 100 different genes in just the right way. That would be looking for a needle in a haystack. So there is also this angle, which you bring out, incidentally, in your book, which is the level at which we are doing the analysis. And I'd like to ask whether you both want to comment on that aspect of the problem.
Yeah, I want to say something. I want to compare biologists and physicists. The physicists have been extraordinarily successful with their public relations in getting fairly large sums of money to discover new fundamental particles, for example. Governments were prepared to fund CERN in Geneva to the tune of billions of pounds in order to find the God particle. And it was projected as being, we are going to find the God particle. And the money was coughed up. It was excellent PR. Yeah, and it didn't really matter that it wasn't really a God particle at all. It was certainly a good thing that the Higgs boson was discovered, no doubt. But it was basically a PR approach. If you do that in biology, you run into problems. If you start saying, I want what is seen as being a large sum of money in order to sequence the human genome, £3 billion was the total cost, then and you therefore have to make promises as to what it's going to deliver, you better be sure, you need to be more sure that you are going to be able to deliver what it is that you say, because the consequences are much more close to people's lives. You know, if you start saying, I want to sequence the human genome to find a cure for, because I will find a cure for cancer, you know, which is what was said in the 1990s, you are going to run into big trouble when that doesn't show up.
Well, we've already run into that trouble.
Yes.
That's
and
correct.
If we want to have more big projects in biology, we have got to come clean. We have absolutely got to come clean. We can't be doing public relations stunts. The physicists can get away with it. We can't. They can say there's life on Mars. Let's go to Mars. We can't make comparable promises. We just can't do it, because we're going to be shown up for what we are if we do that. We have to tell the truth.
Frankly, liars. Yes.
Well,
Bill, do you want
Yeah,
to
just going back to your point, Denis, about you know, trying to justify using the information from, say, the whole genome project in terms of trying to use it to certainly help medicine and disease. I think clearly we're talking about conditions here where they have an incredibly complex etiology. That, you know, it's not as, in most cases, it's not as certainly not a single gene, it's multiple genes,
right.
could be 50 genes, could be more.
Yeah.
And they're all going to be interacting or additive or what have you. And the interface of that is really how it interacts with the non-genetic factors, the exposures that we deal with day to day, year to year. And the problem is our knowledge of the external exposures, other than identifying through epidemiology a statistical relationship, how that interface is largely unknown, you know, and people, it's the hardest area to actually investigate. You know, the genetic aspect, even though it's highly complex, has been the most straightforward, because it's just been waiting for the right level of technology to come along to enable us to do it. And, you know, we can now do it faster and cheaper than we could ever think of 10 years ago. But to try and work out the actual underlying mechanisms, how particulate pollution or body fat or exposure to radiation or anything, how that interfaces with that complex genetic structure is still a mystery. And largely it's a mystery. But that's really how it's been solved. And I think it is. I think what people have been thinking, if we could actually identify through genetics a complex risk profile, well, then you could have sort of targeted prevention. You might be able to home in on those individuals and actually tell them that they have a much higher risk, and they should be even more mindful about how they go about their everyday activities. Yes. But that will still never happen. So I think in a way it was a bit of a fudge, but really even that targeted intervention to people who might be high risk, you know, there are some examples. For example, emphysema. You know, we've known for many years that people who have a rare mutation of the alpha-1 antitrypsin gene, if you're homozygous for that ZZ variant, you know, and you smoke, you're going to be 100% pretty well, 99% certain to get emphysema. Have we ever used that in our public health for screening? No, we've never done that. So to try and think that they'd do that for something where there may be 30 or 40 genes involved, I think is fanciful. So I think we've got to really deal with the cards that we've got in our hand, which is, we know from epidemiology, obesity causes risk, sedentary behavior causes risk, poverty causes risk. We've got to actually just try and do it in a systematic way. And the way to do it is at the whole level of society. I don't think we're going to be able to really target it to that individual level. But the whole way it's been sold has been personalized preventive medicine. And that's been targeting this drug, and that's fine. In some cases, we can do that for medicines.
Yeah.
To try and think of it in terms of targeting for complex longitudinal conditions or long-term conditions is going to be very, very fanciful, I think, at the moment.
Well, you've almost summed up where I was going to sum up at the end of this webinar, and we are indeed now just within a few seconds of the end of the webinar. So I don't think we could have had a better summing up of the state of play than that. And I want to thank you very much for that. And since we are now at the witching hour of just 10 seconds remaining, I want to thank everyone who's contributed to this webinar. Sorry that we didn't have one of our contributors online. The Oxford Longevity Project, think how to deal with that future if we do another webinar sometime. But in any case, I want to thank Martin and Bill very strongly indeed, and of course all the organizers of the Oxford Longevity Project for what's turned out to be a very important highlighting of issues that have to be taken right up to government level and right up to the level at which action could be taken. And with regard to that, watch out for a future Oxford Longevity Project webinar that may indeed be talking to the very people who are trying to achieve that. So thank you all very much. And with that, I'll close this particular webinar. Bye-bye for now.